Okay, it's 5:30. Good evening, doctors. I think our Friday online webinar will start soon. Today, I'm very glad and very proud we invited Dr. Conti join us. And Dr. Conti is a global famous implant speaker. So later I will ask the director of the Sweeten Martina in US, the director Reddick, to introduce Dr. Conti. Thank you for all you join our webinar. And in first week of May, we are in our group. We are going to have a Guatemala live patient implant training. Here, I just thank you, Reddick, represent the Sweeten Martina to support our training in Guatemala. Yeah, and since that, I studied the implant, especially for the primer. It's a wonderful product. Yeah, I'm glad that we introduced the primer to our doctor. So right now, I just give the time to the Reddick, and let Reddick have the webinar opening and introduce Dr. Conti.
Wonderful. Thank you. Thank you very much, Dr. Zhang. I appreciate that. Can you hear me?
Yes, good.
Okay. Yeah. My name is Radek Kosek. I'm the National Sales Manager for Sweeten Martina Inc., the branch of Sweeten Martina. Sweeten Martina is based in Italy, just outside of Venice, Padova and Venice. First, before I introduce Dr. Conti, I would like to thank everyone for getting on this webinar on a Friday, and appreciate you joining us. And I would mostly like to thank Dr. Zhang and Dr. Xu for giving us this opportunity to be here and to connecting us with your group and with your dentists. And it's a wonderful opportunity for everyone. And so when we started to talk about doing a lecture, we wanted to bring somebody who could speak about this unique approach, this unique implant. And we were able to have Dr. Stefano Conti do the presentation for us. Dr. Stefano Conti received his dental degree at the University of Medicine and Surgery School of Dentistry in Parma, Italy, 1989. He attended courses in Atlanta with Dr. Garber, Dr. Henry, Dr. Salama, and he also completed a guide course at the UCLA with Sasha Jovanovic.
Correct.
He's a lecturer in the master program in implantology at the University of Parma. And he's also a master program lecturer at the University of Parma for facial aesthetics. He lectures all over the world and some of the countries. He lectures in Italy, he lectures in Europe, South America, and actually in late April, he will be doing a series of lectures for us in the Northeast. And he's involved in a private practice, but he also works in Kiev, Ukraine, where he's restricted his clinical work to implant surgery. And I'm personally extremely happy to have him lecture to us. Dr. Conti has tremendous energy, and he has been working with this Prama implant for a number of years. And I'm just happy that he'll be able to share with you a very unique approach to implant dentistry and with this very unique implant. So thank you for your time, and welcome, Dr. Stefano Conti.
Thank you, Radek. Thank you for the beautiful introduction. Thank you. Thank you, everybody, to be here tonight. And I'm really happy to be here anyway. Thanks to you. Thanks to Sweeten Martina. Thanks to Dr. Zhang for the invitation. So I'm just here to share with you, all right? Feel free at the end of my presentation to ask me as many questions as possible. And well, today I'd like to share with you kind of a new concept in achieving aesthetics with implants, okay? I called my webinar Prama, the vertical freedom concept. And I'm gonna show you why I think like this, all right? So anytime we think about aesthetics with implants, we should think about form. All right. 4 means that volume we lost while missing the teeth. So we have to recreate the volume. With the volume, I mean, we should know how to regenerate bone, but also even more importantly, we should know how to manipulate soft tissue. And what about the components, the implant, the abutment, the emergence profile, the prosthetic contours? All these things together actually can work in synergy in order to achieve the aesthetics, the final outcome, right? So one more thing, which is extremely important. We know today that the implant design, the morphology, the size, the surface of the implant can really affect the implant placement. All right. So depending on the implant design, we should think differently. So just to give you an idea of what I mean when I talk about PRAMA, I'd like to share with you also, or will at least share with you, which is the contemporary scenario of implant dentistry so far. What do we know today? Well, we know that we have a few factors that can really affect the crestal bone stability. So which are the implant design factors that they can really affect the crestal bone stability? Well, for sure, the microgap, and then the polished neck of the implant, the mirror polished neck. Anytime we think about the implant abutment connection, depending on the microgap size and the stability, where we have microbial leakage, right? That's a problem we've been dealing with for so many years. We want to reduce the microbial leakage in order to have a stable bone and soft tissue around our implants. And on the other side, anytime we think about a transmucosal implant with a mirror polished neck, well, of course, it's going to work because we want to keep the implant abutment connection at the soft tissue level, but we also know that the polished neck is not going to be also integrated. So we can't work with the polished neck into the bone. So these are the limitations of a bone level or transmucosal implant. And again, today, what do we know today? That anytime we work with a bone level implant or tissue level implant, well, what have I been doing in order to reduce the crestal bone loss? Well, we've been working, for example, with the platon switching. All right. So with or without platon switching, we can work with the implant. And also, we've been working on the transmucosal or tissue level implants. But again, this is not enough. Sometimes that's my clinical experience. I've been placing implants without platon switching, just place the implant. And I had a beautiful final outcome for so many years. Other times I've been placing an implant with the platon switching. I've been placing my implant a little bit deeper, but then after a few years, I had a resorption, I had a bone loss around, and I didn't understand why. So I think that this is not enough. Of course, the design is important, but also even more importantly, we have to deal with biologic factors. We have to deal with the soft tissue crystal thickness. Anytime I do place an implant, I want to evaluate the soft tissue thickness. We know that anytime we place an implant and we have at least 3 millimeters of crestal soft tissue thickness, well, better 4 millimeters. Well, we know that this amount of soft tissue is the one is going to recreate the supracrestal tissue attachment. So, you know, of course, the implant design is important, but also biological factors. So with PRAMA, we can really play fundamental, we can really play in synergy with the biologic factors. That's what I like about PRAMA. And I'm going to show you now a case. That probably was the last case I've done with a bone level implant from Zhang and Martina. It's a simple case in the aesthetic area. I had to place the implant on the upper left one. As you can see, I've been working also on the natural teeth with a vertical preparation with the BOPT concept, which is another concept that comes actually the Prama also comes from this kind of concept, the vertical freedom, okay? That we work also on natural teeth like this. And what's happening? I choose the implant. There was a bone level implant with a very short neck, 0.8 millimeters of UTM surface. That was the first one. This is the father actually of Prama. And well, of course, it's an easy case. As you can see, I have a huge amount of bone and soft tissue. So it's easy, predictable. I just need to place the implant in the proper position. I just need to work with the soft tissue at the stage, manipulating the soft tissue with my temporaries, and just have to wait. Day by day, the soft tissue is going to adapt on the emergence profile of my temporary crown, both on implant and natural teeth. So as soon as I recreate an ideal aesthetic gingival architecture, then I'm ready for the final outcome. Easy, predictable. So am I good? No. Am I lucky? Only because at this stage, everything can work. We can place an implant bone level with or without platen switching. Since we have a huge amount of bone and soft tissue, for sure, everything is going to work perfectly. Okay, so we have to think like that also. And we can really recreate with very easy surgical technique, a beautiful buccal aspect of the soft tissue. This is what we got. But again, the supracrestal tissue attachment is fundamental as soon as we have a crestal soft tissue thickness. All right. So if you think like this, then Prama is going to help us, is going to open our mind, and we can work differently. This is the final outcome, easy and predictable. So again, I'm talking about Prama, but Prama at the end of the day is an implant. And we can think like a bone level implant if needed. But of course, if we do that, we're going to miss a few opportunities that we can have with Prama. Prama is a little bit more, I think. So crestal bone loss, well, not at all. Albertson, 1985, says that every year we lose the first year we lose 1.5 millimeters, and then every year we lose something. That's not true. If we can really manipulate the soft tissue, if we can really create a real biologic seal around the implant, then everything is going to be stable. That's what I think. So again, after 4 years, bone level implant without platen switching is going to work. All right. So why Prama? Well, Prama has got a body. Let me move here. Prama has got a body, but also even more importantly, Prama has got a neck, 2 millimeters of convergent neck and 0.8 millimeters of cylindrical portion. That's key to understand the advantages of Prama. And then when we look at the neck of the Prama, well, we have, as I say, convergent portion and then cylindrical one, 2.8 millimeters. The surface is a UTM surface. That means ultra thin treated microsurface, which is ideal for osseointegration. We have human histology here, but also, even more importantly, is perfect for soft tissue. And I really think that today the real challenge is not bone regenerations or anyway how to manipulate bone, which is necessary sometimes, of course, but the real challenge is soft tissue manipulation. As soon as we recreate a barrier, a real biologic seal around the implant, well, we're pretty sure that the final outcome is going to be stable for many years. So think about the neck, which is ideal for both bone and soft tissue. First thing. Then look at the profile of the neck with this convergent profile, which is ideal because the coronal part is going to be narrower, and then soft tissue is going to adapt and get thicker and thicker the more coronal we go. So, you know, even the design is ideal. Plus, if we think about the UTM neck, well, I think that, and I will show you clinically speaking, that around the neck, we have all the time the fibroblasts that organize in bundles. So we have thick ring of stable tissue that remains adherent to titanium. And I love that because in my opinion, clinically speaking, anytime I have a seal around the neck, well, I feel confident that we have a natural barrier for the implant to the external world. And again, which is the ideal positioning? I call this approach a vertical freedom concept. As you can see on the left side, we have the neck of the implant with the transition zone. The cylindrical part is called the transition zone. So I want the transition zone to be subcrestal all the time. I want this transition zone to be into the bone. On the other side, on the right, we can also work with the PROMA like a bone level implant. So we can put all the neck into the bone. Nothing's gonna happen. But in between the two different positioning, we have in the middle the opportunity to, I'll show you here, to have always the implant platform, the implant abutment connection far from the bone. So ideally speaking, I'd love to have the implant platform at least 1 millimeter from bone. Then average positioning, 1.5 millimeter. This is the ideal positioning of the implant, because this way I don't miss the opportunity to have a vertical platform switching, and the micro gap, the implant abutment connection, is far from bone. So why I want to miss this is a huge opportunity to keep the implant abutment connection far from bone, to keep and have a biologic seal apical to the implant abutment connection. That's the key to understand PROMA. And again, transition zone into bone, or you can place all the implant into the bone, depending on the clinical situation, depending on the clinical aesthetic goals we want to reach. All right, depending on the case, but think about this. And then in the middle, you can play with your vertical freedom. Again, when we think about the PROMA placement guidelines, I will show you how to place it. It's easy. When we think about, I'll give you just an example, 10 millimeters PROMA, the nominal length is referred to the body of the implant, okay? So when I think like this, 10 millimeters implant means that I have to use the 11.5 burr if I want to place the transition zone at least into the bone. So to me, anytime I open an implant and I see 10 millimeters length, to me means 11.5. So I have to think like that. And transition zone is going to be with at least the cylindrical part into the bone. It's easy. So we have, but it's not enough. It's not enough. If we decide, and we do the planning in the first place, to place the implant a little bit deeper, well, first thing first is planning. When we decide where to place the implant, then it's easy because, again, we can use the implant 10 millimeters length, nominal length, with a bore 13 millimeters. And when this way, we place the implant into the bone. All right? So I want to stress the concept, because if you look at the nominal length, 10 millimeters, we always have to think with the bore of 11.5 to place the implant and the standard positioning. If we want the implant to work as a bone level, we have to think with the bore and prepare the implant placement for the 13 millimeters burr. All right, easy. See, as I show you on purpose some PROMA implant that are going to work like a bone level implant, because I will show you later on that we have cases where we are supposed to place the implant deeper, depending on the case. So just think like of PROMA like a normal implant. But then, since it's a normal implant like many others, but with a specific neck, we have the opportunity to work and have advantages. And I'm going to show you now here. We have different peri-implants of tissue. Why? Again, we can have a huge peri-implants of tissue or we can have the neck almost exposed, or we can have the neck of the implant which is exposed from the soft tissue. But why? It depends on the clinical situation. Every day on Monday morning, I have to deal with cases like this. After the extraction, I'm going to lose the bundle bone. I'm going to have a defect. Every day on Tuesday, I have another case where all the bundle bone is gone. So ideally speaking, it's easy to work with all kinds of implants. But in our everyday dentistry, we have different clinical situations where most of the time bone and soft tissue on the buccal is compromised. That's why Prama is going to help us. Again, here, very easy case. But if you look carefully, we have a little bit of a defect on the buccal, horizontal and vertical defect. So how do I think with the bone level implant? I will show you. Again, here, after the extraction, we compromise the buccal aspect. Or here, even here, for example, we have a buccal defect, easy case. And when I do the flap and I raise a flap, what I find, I have a crestal defect on the buccal. So the decision I have to make with a bone level implant is I have to place the implant deep into the bone. So I have to place the implant apical. With Prama, this is the final positioning. As you can see, mesiodistal, the neck of the implant is almost at bone level. On the lingual side is bone level, but on the buccal side, part of the neck is exposed. The transition zone is into the bone, and the convergence zone portion of the neck is exposed. In this area, nothing's going to happen. We have soft tissue. It's going to be very, very easy. We can place some biomaterials if you want to, just to keep the space as a scaffold, but no more than that. And part of the neck will be exposed. Plus, even more importantly, if you look at this, I want to place the implant abutment connection nearby or a little bit more apical to the adjacent CJ of the adjacent teeth. I don't need to place my implant so deep. So I can still place the implant with part of the neck exposed, but still nearby the CJ of our adjacent teeth. And again, if you think like this, as you can see in the drawing on the right, we have on the lingual side, the implant, which is at the bone level. On the buccal, part of the neck is exposed. This is what I like about Prama. We can really play every day in our different clinical situation with the neck and define the final positioning and let the part of the neck exposed. Nothing's going to happen. And again, in this case, I have to think differently. I have 10 millimeters, for example, 10 millimeters length. Well, this is the body of the implant, but I have to use the 13 millimeters burr in order to get on the lingual part at the bone level. Easy, okay? Again, we have different situations, but look at this. All different clinical situations have got the same result. I have part of the neck, all the neck, 1 millimeter, 0.5 millimeter, depending on the clinical situation, but the neck is exposed. And I want this to happen because this way we have the vertical platinum switching. The micro gap is far from bone. And around the neck, we have blood, we have clot, and we have the soft tissue that is going to organize itself and adherent to titanium around the neck. And also, we can place the implant, prosthetically speaking, in an ideal 3D positioning. All right? So, different situation, different peri-implants of tissue. I think, but this is only my clinical experience and my opinion, that with Prama, we have the benefits of one-piece implant and the advantages of two-stage implant. Because apical to the implant abutment connection, we have the biologic seal. And that's amazing. All right? Again, I want to stress the concept. transition zone, always into the bone. But again, we can place the implant at the bone level. In between, we have the ideal positioning with the transition zone always subcrestal and the implant platform at least 1 millimeter supracrestal. If I can do that, I'm going to achieve all the advantages of PRAMA. If I cannot, because the clinical situation doesn't allow me, okay, I can work like a bone level implant, it's okay. I'm gonna show you now a clinical case just to give you an idea. Very easy case with a huge, beautiful quality and quantity of soft tissue. But again, I can play differently from a bone level implant. When I do the incision, what I do usually, I want to evaluate the crestal soft tissue. And as you can see, I place the PRAMA. Of course, bone is important, but not so crucial and critical as much as when we're dealing with a bone level implant. So I place the PRAMA differently. As you can see, the neck of the implant is exposed differently. Why? Because I've been looking at the CJ or abduction teeth. I've been looking at the free gingival margin over the ideal gingival margin. I'm going to recreate by manipulating the soft tissue with my temporary crowns. So different levels. Why? Because I know that the neck of the implant is going to be the biologic seal. And I want the implant abutment connection to be of the two adjacent implant. I want them to be at the same level. So I have such a huge advantage when I work like this. And then again, the implant abutment connection is at the same level nearby the CJ of adjacent teeth. Ideally speaking, when I have this kind of reference, I like to place the implant abutment connection at the CJ or a little bit more apical. And if I have a gingival margin, ideal gingival margin, I like to think that the implant abutment connection is 1-2 millimeters apical to the ideal gingival margin. And again, part of the neck will be exposed. Doesn't matter. On the right side, we have 2 millimeters of exposure. On the left one, we have 1 millimeter, 1.5 millimeters. But we have the vertical freedom. So we just evaluate the thickness of the soft tissue. What do we have to do? Nothing, zero. We just place the implant. I used to work a little bit with biomaterials. I don't like them, but at least they keep the volume as a scaffold. I just have to wait. And then biology, our body is gonna work for us. The implant and the biologic factors are gonna work for us. After 2 weeks, suture removal. After 1 month, day by day, soft tissue is going to adhere around the neck of the implant. And I'm thinking about the neck like the real biologic seal. See, after 1.5 months, and then after 2.5 months, comes the time for the final prosthetics. At this stage, what I can do, well, it's easy. I can work with my temporary crowns and recreate an ideal gingival architecture. Okay, this is the final. Then I want to develop a proper emergence profile. And how can I do that? Well, just manipulating the per-implants of tissue with a temporary crown. And what's more interesting here, I can go in the first place with the temporary crown on the neck of the implant if needed. I want to, in a way, recatch the soft tissue and recreate the ideal emergence profile of my crown, on my soft tissue. So I can work with the aesthetic zone of the temporary. I can work with the boundary zone of my temporary crown. And day by day, by manipulating the soft tissue, I can achieve a nice aesthetic final result. So after 2-3 weeks, this is what I've got. Day by day, I can achieve this. I can recreate the gingival architecture. And as you can see, part of the neck is exposed. And apical to this area, I have my biologic seal on the neck of the implant. All right. This is what we can achieve with Prama. Just doing nothing. I just want the neck to work with us. And then comes the time for the final crown. So, but as you can see, I can develop an ideal gingival architecture, and I can remove and replace the temporary crown as many times as I want without harming the peri-implants of tissue. Because again, the biologic seal is apical to this area. From here to here, day by day. Okay, this is what we can achieve with Prama. Again, we have also prosthetic factors that can really affect the crestal bone stability. So anytime we place Prama, we should think also from a prosthetic point of view, which is the ideal emergence profile, which is the ideal positioning of the crown on the neck of the Prama, at the implant abutment connection. How can we achieve a nice result with the prosthetics? Well, we can work with the tie base, we can work with the milled abutment, we can also work with a monolithic crown, cement screw train crowns, of course, not cemented, but we can work, and the neck can be part of the prosthetic. I can decide to place the emergence profile of my crown 0.5 millimeters on the neck of the implant. I can also go with a customized prosthetics around the neck of the implant, like emulating the CJ of Adichie teeth. I'll give you an example. I had to place an implant on the upper left too. So after the extraction, we have beautiful socket, we have fix of tissue. Everything is easy, predictable. I place the implant in the proper position. And again, when I have soft tissue reference, I like to think that the implant abutment connection is 1-2 millimeters apical to the ideal gingival architecture. This is the final position. And again, see the prosthetics. The emergence profile of the prosthetic is important. But when we think with a bone, utilizing a bone level implant, well, we have to work on the abutment. And then after we work with the abutment, then we can actually recreate the emergence profile of the crown. With Prama is different, because most of the time we don't need such a long abutment, but the crown starts right away where we have the implant abutment connection. And we can also work with a huge emergence profile, because we are still giving the space for the soft tissue. So we have an aesthetic zone, which is 1 millimeter apical to the ideal gingival margin. We have a bounded zone that can be convex, straight, concave. So we got the freedom actually to work with the prosthetics without harming the quality and the stability of the soft tissue. Because again, we have the crestal zone. In a bone level implant, the crestal zone is located immediately coronal to the implant platform. With the Prama, the crestal zone is on the neck of the implant. So it's completely different. It's a complete different situation. So if we have a biologic seal apical to the implant abutment connection, well, we can work with the crown, the final crown. We can remove the crown as many times as we want, and we can work with the emergence profile the way we want in order to achieve, in order to manipulate the soft tissue. That's a huge advantage. So again, I can also decide to get on the neck of the implant. And this is the final, easy and predictable. Again, another case in the distal area, one single implant. Some people told me, well, you know, but the neck is got a connection which is 3.3 millimeters. Is it going to be strong enough for a single implant on the molar? Well, yes, because I can think differently. With Prama, I can still place a 3.3 implant connection because the neck is standard 3.3 millimeters. But as you can see, I can work with the crown, with the Prama in on the neck of the implant. 0.5 millimeters on the neck of the implant. That means that I got the ferrula effect. And from a biomechanical point of view, I got the strength, I got the stability of the prosthetics. So it's easy, it's kind of predictable. And again, I like to think that anytime we work, even in a distal area where we don't have such an aesthetic issue, but I still want to have stable soft tissue. This is what I have even around the molar. Okay, and I like to think that around the neck of the implant, I have a thick ring of stable soft tissue. I have the real biologic seal. Again, the implant abutment connection is far from the bone. And I got the space for the soft tissue to heal around and seal my implant. Even when we're dealing with multiple implants for our FP1, for example, for immediate loading, as you can see, I have so many different clinical situations, but just to give you an idea, most of the time when I can do that, when it's achievable, I like to think that the neck of the implant is my multi-unit abutment. I don't need multi-unit abutment. As soon as I can plan the implant positioning without utilizing MUA, for me is a big advantage. The neck of the implant itself is my MUA, my multi-unit abutment. So I don't need that. And the less components I use, the better it is for the stable prosthetic final outcome. Again, even in the lower, always think like I need to evaluate the thickness of the soft tissue, of course, but again, the neck of the implant is my MUA. I can work with some biomaterials in order to increase the thickness of the soft tissue, like a 10-pole technique. The neck is ideal for a 10-pole technique. I don't need to place healing abutment in order to maintain the volume. The neck itself is my 10-pole technique. Even with the guided surgery, we have, I think, this is my personal opinion, but clinically speaking, we have so many advantages because with a fully guided approach, we just plan the case in the first place, right? So we can decide. I'm not here to lecture you about the predictability and the advantages of surgical guide. Of course, anytime we plan the case with a surgical guide, we have the advantages to plan the implant exactly where the implant is supposed to be. And we can play with the neck of the implant. Should we place the neck deep into the bone? Should we place, for example, in a tilted implant, part of the neck into the bone, part of the neck out of the bone? Or we can use the neck of the implant like a multi-unit abutment. Depends on the case, but on purpose, I'm going to show you a surgical guide and a case I've done with a surgical guide, fully guided, where I had to place the implant deeper, like a bone level implant. So think like this. Prama is still an implant, and I can place the implant like I do with the bone level if needed. Why not? So after the ideal setup, I do plan my implant placement. As you can see here, I have the neck of the implant, which is 1 millimeter, maybe at the bone level sometimes, depending on the case. I can decide to place the implant deeper. In this case specifically, I did place the implant at the bone level. because I had to work with MUA, because I had, after the extraction of the teeth, I had a compromised bundle bone. So I can work like a bone level implant. That's what I've done here. And as you can see, the implants are deeper. So don't think of Prama like a transmucosal. Think of Prama like an implant, bone level implant, with the advantages of one piece and the benefits of two-stage implant. So I can work with the neck, try my best when it's possible to keep the implant abutment connection far from the bone. That's what we can do here. Again, when we get, for example, just an example, we do a fully guided surgery, we have the temporaries here, but again, we can play with the biodynamics of tissue shaping, and we can play with the abutment on the neck of the implant, depending on the final aesthetic outcome. But we got the freedom to decide where we can start with our emergence profile of we can do and go on the neck of the implant or keep it far from the neck of the implant. So we got this kind of freedom. See, again, this is the temporary final, and then the case is done. And you might ask me, well, what about if when I place the implant so deep, I've got a disposure of the neck of the implant? And I can tell you, what about if you work with a bone level implant and then part of the body of the implant is exposed after a few months because the remodeling of the bone? So anytime I place the implant a little bit more deeper, well, I know even if after the remodeling of the bone, we have the exposure of the neck, well, nothing's going to happen because the neck is ideal for soft tissue. So I do not expose the body of the implant, but I still expose the neck of the implant. And around the neck of the implant, I have the real biologic seal. So diagnosis, planning, and positioning with Prama, I think, is much easier because at least we have 2.8 millimeters of advantages. I'm going to show you one more case with a guided surgery now, where because it's quite interesting. Because again, here when we plan the case for in a aesthetic zone, we can really think different with Prama. What we do here, first thing first, we should plan the case from an aesthetic point of view. So anytime I think about the aesthetic zone, I want to, through the digital smile design, I want to recreate the ideal positioning, shape, form of the tooth I want to recreate, and also the ideal gingival architecture. I study my case from an aesthetic point of view. Then after that, I can also evaluate, which is the next step, which kind of surgical approach should I go through in order to achieve ideal gingival architecture, for example. So I plan my case thinking of Prama completely different because I know I can work with the biologic seal on the neck of the implant. So I plan the case from a surgical point of view. I study my case as well on the model, which is the amount of soft tissue I need in order to recreate the ideal gingival architecture. I ask my laboratory to give me the temporary crowns, and then we plan the surgical from here to here. And then with the surgical guide, again, we decide to place the implant exactly in that position. And very comfortable when I play this with Prama for many reasons. For example, if I have to place the implant in the aesthetic zone, I don't want the neck to be exposed, so especially when I have to deal with a case where the axis, the inclination of the implant is different from the axis of the prosthetics. Of course, we have pre-made abutment, we can compensate the position on the screw. But Again, with Prama, in this specific situation, I can decide to place the neck of Prama a little bit deeper, 1 millimeter exposed only. As you can see here in the planning, I decide to keep 1 millimeter of the neck exposed. I don't want to get with the neck out of the bone. It's much easier. At this stage, I place the implant. Sorry. I place the implant in the specific position, 0.5, 1 millimeter exposed from the bone. And then I just have to wait. But what I like about it, we plan the case and we place the implant exactly in that positioning with the implant abutment connection far from the bone. Then with a temporary crown, we just have to manipulate the soft tissue. We just have to wait. I can actually remove and replace the temporary crown as many times as I want without harming the quality of the peri-implant soft tissue, without harming the biologic seal, which is again on the neck of the implant. I'm still working with a temporary crown. This case is submitted for an article. I'm not going to show you the end of it, but from here, you can easily think that it's very easy to achieve a nice result. We just have to work on the temporary, adding a little bit of resin, and then we can recreate and remodel the shape, the ideal shaping, and the ideal gingival architecture around the implant. From here, after 3 months, I just need to work on the temporary. And again, which is interesting, I can add resin also on the neck of the implant. So from here to here, I can recreate a new emergence profile of the crown. And when needed, I can go on the neck of the implant. This is what I call the biodynamics of tissue shaping. See, we have the vertical freedom to decide, which is, again, the final positioning of the emergence profile. Again, we have to deal with an aesthetic zone, which is 1 millimeter apical to the gingival margin, banded zone, and crestal zone. We just have to wait, and day by day, we can recreate ideal gingival architecture. All right, so now one last case I want to show you, still on the aesthetic zone, with a few more concepts about Prama, and then I'm ready for you for the final questions. I'm going to show you now one more case, a central incisor. Anytime we're dealing with a case like this, as soon as we extract the tooth, are we sure we can maintain a bundle bone? Well, I'm not that sure, but again, with Prama, we have 2 millimeters of advantages. So after the extraction, I do the mapping on the socket of the alveolus, I place the implant. I've been working with a delayed implant loading, and I've been waiting 3 months. Again, we have the biologic seal around the neck. We just wait. Comes the time for the loading 3 months later, and then with the temporary crown, I can recreate the ideal gingival margin. How can I do this? Well, simply adding or removing resin on my temporary crown until I get the perfect shape of the gingiva. Because the biologic seal is apical to the implant abutment connection. This is what we can achieve, all right, with the temporary crown. Then we go to the final with a cement screw retain restoration. In this specific case, I've been working both on natural tooth and implant with a vertical concept. So a vertical veneer on the 21 and an implant with a monolithic abutment with a vertical preparation. I'm gonna show you here. See, I've been thinking differently. Since I can remove as many times as I want the components, since I'm not gonna affect the stability of the implant abutment of the soft tissue, I can work differently, and I can have a monolithic abutment on the implant, the same shape and color of the tooth preparation. So I work with the veneers in this case, and I can achieve final aesthetic result with ease and predictability. Again, the emergence profile is important. And when we work with the emergence profile of our abutment, of our crown, we have to think differently. We have an aesthetic zone with a circular epithelium. We have a banded zone with a junctional epithelium and apical to this area, the pocket epithelium. And again, what about the crestal zone? What about the biologic seal? What is the connective tissue? Well, connective tissue is on the neck of the implant. Here we have the real biologic seal. So I want to stress one more time the concept. Aesthetic zone, 1 millimeter apical to the gingival margin. Banded zone, convex, straight, concave, doesn't really matter. Depends on the clinical situation. And then crestal zone, which is the key to understand Prama. And in this area, we have the real connective tissue, the real biologic seal, the real natural barrier for the implant to the external world. So we get to the finals with ease and predictability. We have the biologic seal, and with the biologic seal, we have the implant success. Again, even with the final crown, we can remove the crown and replace the crown as many times as we want, without harming the quality and the stability of the peri-implant soft tissue. So at the end of the day, why Prama? Why I choose this unique implant? Well, for me, Prama, it's easy. It's a simplification. I can work with the vertical freedom, positioning the implant at different levels, depending on the clinical situation. As many times as I can, I try my best to have the implant abutment connection far from bone. That means the vertical platform switching. And the macro gap is far from the bone. I can still think differently because while I'm placing the implant, I can place the implant abutment connection as a reference nearby the CJ of adjacent teeth, 1 millimeter apical to CJ of adjacent teeth, or 1-2 millimeters apical to the ideal gingival architecture. And in this way, if you think like this, then if you think about Prama, then you are minimal invasive. And you have a biologic seal around the neck. And with the biologic seal, we have soft tissue stability. So how can I say, at the end of the day, for me, I have a simplification, and the simplification is the ultimate sophistication. All right. So thank you. I've been trying my best in a very short time to give you as many details as I could. And I just want your opinion. I want so many questions.
Thank you so much, Dr. Conti. It's a very impressive. It's a beautiful case presentation.
Thank you.
Very nice. Okay, next is our question and answer time. And before that, I want to introduce our Guatemala Live Implant Training's main speaker, Dr. Stephen Xue. Dr. Xue, you are here? Are you here? And Jesus. I really appreciate Jesus help Jesus is the representative of the Sweet Martina. Yeah.
Yes, hi, hello, everyone. I'm here.
Hi,
Hello.
how are you?
Hi.
Yeah. I want to first introduce Dr. Stephen Xue. And this time, actually, it's Dr. Stephen Xue initiated this live patient training. And Dr. Xue already did the many times the training in UFM, the dental school in Guatemala. And some of the very famous dentists, implant dentists in China, get training by Dr. Xue. And Dr. Xue
nice.
is great. His clinical skill it's very, very impressive. Okay, I think right now we already have the 12 doctor join the Guatemala live patient training, and so I give the time to Dr. Xue. Do you want to say something?
Hey everyone.
Your speaker mute, Dr. Xue.
Yeah, correct.
Hey, good evening, everyone. Thank you, Dr. Conti, for giving us such a wonderful lecture.
Thank you.
I
Thank
think
you, sir.
all of us benefit from it a lot. Yeah, the new concept is, soft tissue management.
Correct.
You mentioned a lot about connective tissue, and soft tissue seal is the paramount foundation for the success of the implant, which we all being try to achieve that, even to this day of placing many implants. It's a struggling for all of us. From your lecture, we certainly learn a lot, and with the new concept from Plama implant. And personally, I place few, but after your lecture, I'll give me a different view and different angle how to place them. And for that,
Nice.
I'm really thankful for that.
Thank
and
you.
without,
Thank you very much.
This is our first time training a U.S. doctor to UFM, University of Flamenco in Guatemala. It's a very nice private university. They are the dean, vice dean, and the director of the implant department. They all graduate from NYU. So the facility is amazing. Dr. Poche and I, we visit there a few times, bring the Japanese group and Chinese group. So hopefully we can set a good platform there. In the future, we invite Dr. Conti to come along with us.
That will be my pleasure.
Yeah. We definitely. And also, Dr. Zhang has been very diligently labor for the Chinese, U.S. Chinese dentists in his digital group. That's how we met each other. I really admire his hard work and work ethic. So I'm glad to be able to work with him in this venture, and hopefully we can be have more people will join us. It's all for the good cause, knowledge, make friends, and ultimately we can serve our patients better. That's our goal. And also again, thank you very much for Jesus. He ran into my office one day. There it is. Now we have a good relationship with the Sweden Martina, and also so as Redick. We met a few times already in that short period of time. So I'm really looking forward to work more with this company. Thank you, Dr. Zhang. Thank you, everybody.
Thank you.
Hi, Dr. Jesus. Do you want to say something?
Yes, I'd like I said, I'd like to thank Dr. Xue for giving us an opportunity and for starting this venture, like you said, into this course. where we can take Sweet Martina, its technology, the the new Prama concept that Dr. Conti just presented to your group. I think that we're the cutting edge of implantology, and I hope that we grow together. So thank you so much.
Okay, so that right now we open to the question to Dr. Conti. Yes, some people, some doctor, if you have question, please do so.
Hi, Dr. Conti. Thank you for a beautiful lecture tonight. And I have a few questions about this trauma implant. I was under the impression that we cannot get any focal exposure to the implant, but in your trauma implant system, you can easily expose a few millimeters in the buccal, but still got a soft tissue coverage. That's what's the theory behind that? Is there any limitation of that? How long? What's the minimal or maximal we can get the buccal exposure in that transition zone? That's the first question. Second question is that I see that biologically there's a good functionality, good design, so you can have the implant abutment connection is away from the crestal bone. But does that creating some the contouring is more like a cantilever to me, so it's hard for the hygiene. If you have a more traditional implant, have more like a runway emergent profile, it's easy. To my impression, to my knowledge, it's easy for the oral hygiene. In your design, it's more like a convex shape. Is this good for the hygiene? Thank you.
You're welcome. Okay, if I understood properly the first question, you say which is the limitation of the exposure of the neck, you mean?
Right, and what's the theory behind that? Why soft tissue can, without soft tissue recession, with transitional zone exposure? I found this interesting to understand that.
Yeah, well, okay. I like to think that Prama works perfectly when the transition zone is not exposed. Transition zone for me is an insurance. I have 0.8 millimeters of insurance. Of course, sometimes it might happen that the transition zone gets exposed. Then I'm dealing with Prama like I'm dealing with a bone level implant. Only this. So I'm thinking of Prama like a bone level implant with the advantage of 0.8 millimeters of transition zone, which is ideal both for bone and soft tissue. It's not how can I say, Prama is not a miracle, just an implant, but it's got this advantage. When we have bone remodeling and we are exposing the body of bone level implants, we might be in trouble because we create a huge highway for bacterial contamination. When we expose just the transition zone, because the remodeling of bone, well, hopefully, that's my clinical opinion, we just have, the exposure of the UTM surface, which is still ideal for connective tissue. So again, is it ideal to have exposure of the transition? No, but is it so critical as much as when we expose a bone level implant? Not at all. We still have the insurance. That's why I like to think of the transition zone like this. And anytime we expose even the convergent portion of the neck, since, well, of course, it's easy to say it, but of course, anytime we do expose, we do have the exposure of the neck, we should think also from a biologic point of view. As soon as we expose the neck, we need connective tissue. And we need to know how to manipulate it in order to have the thick ring of stable soft tissue around the neck. And this comes in order to answer to the second question. When you think about convex emergence profile, a huge emergence profile of the crown, yeah, it might sound a little bit weird, but honestly, when we have
a real biologic seal, apical to the implant abutment connection, all this area, and I'm talking about the aesthetic zone, the boundary zone with the epithelium, well, actually, if we manipulate the soft tissue properly, this area, we are not going to clean this area with the floss. We don't need to get into this area. In this area, we have hemidesmosomal attachment and a fixed stable tissue around the emergence profile. But of course, we have different situations again. It's not too easy to answer to the question. What I can say that most of my prosthetic is made with the superpolished zirconia. And we know today that the superpolished zirconia, and especially when we have the emergence profile with the bounded and aesthetic zone, is ideal for soft tissue, I would say, attachment, hemidesmosomal attachment. So I think that this area is like what's happened around teeth. But again, we have an advantage if we compare Prama to a bone level implant, because anytime we place a bone level implant, sometimes we need to place the implant deep in order to have the position of the implant at the bone level. That means that the transmucosal peri-implants of tissue is huge. We have a huge amount of, and the length of the abutment and the length of the crown is higher. With the Prama, since we can start from the implant abutment connection, and since the biologic seal is apical to the implant abutment connection, I think that the bounded zone is not that huge, so it can be stable in time. But again, this is my personal clinical approach. This is my personal perspective, okay?
Well, thank you, Dr. Conti.
You're welcome.
So you might, okay. Now I see the Prama implant has look like the combination of bone level tissue level implant. It's combined the two concepts together.
Well, this is what I understood from Prama after 7 years of placing it. Yes, I think. Okay, to make it simple, for me, Prama is an implant. Period. Just an implant. Okay. But then, depending on the clinical situation, since we have the 2.8 neck with a UTM surface, we can take advantages from this kind of implant. So sometimes, depending on the clinical situation, when we need to work with the neck of the implant and we have a thick tissue, well, we can place the implant and leave the neck of the implant exposed. Why not? But again, we have a prosthetic and biologic positive factor that influenced my decision. If I don't have this kind of situation, I can still play the implant a little bit deeper. I don't want, if I can, place the implant at bone level. Why? Because I'm going to miss the opportunity to have the implant abutment connection far from the bone. That's only because that, okay? But then, again, you can work like a transmucosal when needed, of course, because the neck can be like a transmucosal implant, with the difference that the neck is convergent, not divergent. So we have also in that, in the geometry of the neck, the advantages. But also, even more importantly, we can work like a bone level implant without losing the advantages of keeping the implant abutment connection far from the bone. So that's why I like to think of Prama like this, and I like to think of Prama with at least 1 millimeters of the neck supracrestal. Did I answer to you?
Yes, awesome. Thank you.
Thank you very much.
Thank you. Last question is that I didn't follow that part with full arch cases. You said with Prama multiple implants, we don't need a multi-unit abutment. Is that because you place them parallel to each other, or because of a unique feature of the implant?
Okay. No, look, yeah. Okay, depends on, again, of course, it's easy to say it, but depends on the case. It's a good question. I like it. Most of the time, when I do the planning or my guided surgery, I try my best to avoid MUA. That means that I try my best to place the implant in a position where I can work with the neck of the implant like an MUA. But of course, sometimes we have to deal with tilted implants, and they got different inclinations. Well, for that, we can actually compensate with the pre-made angled abutment. And if we work with the pre-made angle abutment at 30 degrees, we can easily compensate this kind of inclination. So again, I don't think that MUA is necessary unless the position of the implant, because the defect in this area, in this specific clinical situation, does not allow me to place the implant differently, then I have to use a MUA. And when I use the MUA, I place the implant deeper in order not to have all the amount of the component, MUA, supragingival. All right. But to be honest, anytime I place implants, even with a pre-made angled abutment, I can 5% of the cases I can compensate with the pre-made angled abutment without utilizing MUA.
Okay, thank you.
Thank you.
Dr. Conti, thank you for your speak. I have a question.
Thank you.
I saw the different cases you when you finish the implant on the neck part, coronal part of the implant, you did lots of bone grafting. I think for majority cases. So those bone grafting, so what kind of bone grafting you use? Is it regular bone powder or the sticky bone?
Yeah, it's osteobiol.
Is it stick? Is it just the regular bone?
Yes,
is it not
correct.
sticky bone?
Yes. To be honest, I don't like biomaterials very much. So to me, the biomaterials just a scaffold. Okay, so the neck of the implant is the pole of the tent, and I like to think that the biomaterials keep the space in order to recreate a thick connective tissue around the neck of the implant, which is again the pole of the tent.
All right, thank you.
So
And also, and also another question. So when you mentioned about the neck part of the implant has a convergency fail, right?
Yes.
So because of the convergency and increases, the gingival tissue attached to the titanium. I know there is lots of research, they mentioned, the bone cells, integrate with the titanium, there is lots of research supported. But for the gingival tissue, how the gingival tissue, what's the mechanism like attached to the titanium?
Yeah, it's quite easy. We have actually also histology, human histology around it. It's called entropic concept. That means that you have to keep a UTM surface like a surface which is not polished, but machine, very thin machine, ultra thin machine, 60 microns threads. That means the 60 micron threads is ideal for soft tissue. What happens? The fibroblast, according to the entropic concept, when they get attached to the neck of the implant, they find an ideal avenue to adapt on it. And when the fibroblast gets adapted on the 60 micron threads, doesn't spend its energy to get attached, but spend its energy to duplicate itself. Then what happens? See? So if you have, for example, if you have to think differently, fibroblasts that are supposed to get
adhering to a specific surface, but this surface is not ideal for fibroblast. Well, the fibroblast will get attached eventually, but they're going to spend a lot of energy to get attached to the surface. In the case of UTM surface, this fibroblast got immediately into the 60 micron thread. So they just don't spend the energy to get attached, but they spend the energy to duplicate themselves. That's the mechanism. Plus, since we got a convergent neck, we know that the connected ring around the neck of the implant is like a bottleneck concept, right? The fibroblasts around the neck, they try their best actually to get to the narrowest diameter. So it's quite easy to think that when we're thinking about a convergent neck, the fibroblasts, they migrate aurorally to the narrowest diameter. So did I answer to you? We have, at the end of the day, two different aspects to consider. One is geometry of the neck, which is convergent, and one is the UTM surface with a 60 microns, which is ideal for fibroblast adhesion.
Okay, thank you.
You.
Yeah, thank you. Yeah, I think you answered my question. Thank you so much.
Yeah, thank you. Dr. Conti,
Yeah.
can you go back a little bit because your voice not that clear. You have to say to your mic.
Okay.
You too, yeah. Why you go back and then clear? Yeah.
Let me try.
Yeah, this way much better. Yeah. Hello?
Can you hear me better?
Yeah, that's much better, Yeah.
Okay.
Yeah. I have a question. I like the idea of the Parama, the vertical freedom. Yeah.
Yeah.
Parama seems to have both the soft tissue and the tissue level implant, the bone level implant advantage. That's wonderful. One question is because the Parama is the converging like that. I'm thinking about if for the molar area, the
Yes.
wall of the Parama is strong enough. I saw sometimes, the old implant sometimes
correct.
it's broken, something like that. It's happened to you with the Parama?
No, well, yeah, there was an issue we had, I think, years ago. But now, what I recommend to my colleagues, to my friends, is that anytime we have to deal with a single implant in the distal area, well, I want the crown to be on the neck of the implant. So as a protocol, I like to think of a Prama-in abutment. That means that the Prama-in abutment goes 0.5 on the neck of the implant. If I got the abutment going 0.5 on the neck on the implant, then I got the ferrular effect. And from the biomechanical perspective, I got a stronger crown and implant complex. So it never happened to me to have a fracture at that level.
Okay, that's wonderful. Yeah.
Thank you. Is he?
Another question. For the pros part.
Yes.
I saw you have the angle screw, use the tie base.
Yes.
So that means you have kind of the screw like it's a 30 degree. I saw that, huh?
Correct. We can compensate 30 degrees. Correct.
Okay, that's good. Yeah.
Yes, it's very nice. I mean, if you got a pre-made angled abutment, very rarely I have an issue with the position of the screw, because I can really compensate with this abutment, and well, 30 degrees is a lot. So I can really compensate most of the time. We also have a dynamic abutment, but with the pre-made one, like I show you, you can do, I will say, all the majority of the clinical cases. Yes.
Okay. Do you apply this idea to the molar part? I think it's on for the anterior restoration. Do you think we can apply this one to the molar area? Sometimes
I never thought about it. Yes, maybe, yeah, but the main difference in the molar area, if you talk about a single implant, I need to go on the neck. So when I'm in the molar area with multiple implants, I can usually work with a pre-made angled abutment, no problem. Because as soon as we connect 2 or more implants between, I mean, if we have more implants that they are connected in between, well, we can use pre-made angled and straight abutment with any problems. But if we need to work only with one single implant, I would recommend you to have a PRAMA-in abutment, which is an abutment that goes 0.5 on the neck of the implant.
Okay.
Yeah.
Also for the restoration part,
Yeah.
I saw the Prima have the kind of called the comical system. Yeah, you didn't show today the case of the comical system. You know that it's called there's no cement, no screw. They just like
cement screw retained.
yeah,
Cement screw retained.
Yeah.
Yes, we do, you know, with the milled abutment or tie-based abutment, depending on the clinical situation. But I always work with my final prosthetics with a cement screw retained restoration, which is a screw retained restoration at the end of the day.
Okay.
All right, always screw retained. I say cement screw because the crown is going to be cemented on the abutment, and the abutment crown becomes one piece, and then we can screw it to the implant.
Dr. Conti, I think Dr. Zhang was asking about the conical abutment system, you know, the conical. Have you ever used that?
No.
Oh, okay.
No. I'm sorry about that, but it's a very nice opportunity, of course, but I've been always working, like thinking like traditionally. But of course, I have colleagues of mine, my friends in my clinic, they work with the conical, and they're beautiful, beautiful results. Yes.
Okay.
But unfortunately, I don't have experience about this.
Dr. Conti, to clarify, you just mentioned that for the polar crowns, you recommend put the crown in the next implant. Do you mean on the transitional zone, or is it above, right? Yeah, just to make sure I understand the terminology. The next implant is it below the transitional zone, or in the middle, or on top of the transitional zone?
Can you repeat? I can't hear you very well.
Sorry. When you say in the molar restoration, you recommend
Yes.
put the crown in the neck of the implant. How could I guess I missed the concept of neck implant? Is it in the below the transitional zone, or is it above the transitional zone?
I mean, if I understood properly, you say in the distal area, if I get too close to the transition zone with my crown.
All right. Well, maybe you can go back to the slide of the showing the implants pictures.
Let me show you. Let's go back to the.
Right. So can you
Yes,
show me
let
where
me
the
go.
neck implant?
Let me see. So, for example, here you mean?
Dr. Conti, you have to clean the green share screen, then you can share.
Sorry about that. Yes, you're right. Okay, sure. Can you see it now?
Yeah.
So
Yes,
you mean
yes.
here, right? So when you get too close to the transition zone, you mean? Is it correct?
Doctor, your mic is not open.
Oh, I see. Oh, can you show me one more time? I missed that.
You're talking about this kind of situation?
Oh, okay. So you mean that's the neck implant? Okay.
I don't
Look, I
think
can show
so.
you here. See, this is the neck of the implant, the yellow part. And of course, I want my prosthetics, the emergence profile of my prosthetic to get maybe close to the transition zone, but never on the transition zone.
Okay.
If I'm getting to the transition zone, then I'm invading the biologic width.
I see.
So, you know, I have to think like the transition zone to me, let's say, is my biologic width, my implant biologic width. So if I got too close, that means it might happen. It happened to me in the past to get too close to the transition zone. But why? Because I didn't plan properly the implant positioning in the first place. So the implant was too deep inside, or it was too coronal. But anyway, the vertical positioning wasn't proper, and I had to compensate with a prosthetic in order to achieve a nice aesthetics. But that was a mistake I made while planning the implant positioning. See, at the end of the day, the implant, guys, I want to share you this kind of concept. The Prama implant is an implant, and we can use it like a normal implant. It's beautiful because we can really do that. But then if you think like biologic seal, if you think like micro gap far from the bone, then you can start on your own, day by day, developing your own approach on positioning the implant, and you will see, clinically speaking, that you have so many advantages. That's really, you know, I'm not here to lecture you. I'm just sharing with you my clinical perspective, and it really works like this.
So Dr.
Okay.
Zhang,
Yeah.
so for the convergent color of this type of implant, so the material is zirconium, titanium. Is both, you know, coating by the zirconium. So the material called zirconium, you know, oxide and titanium. But the ball for the implant body is only titanium, right? When you design this implant.
Yeah.
So what's the, you know, the concept behind, you know, why the color part, you use a different material, you added, you know, the zirconium, you know, material there.
Yes. Okay, we have different situations we can deal with. Standard situation, we can go on the neck of the implant with a titanium base, which is called Pramain titanium base, and it's got 0.5 millimeters on the neck of the implant. So titanium on titanium. We also have a Prama designer. I mean, we can actually create from a digital impression, we can create with the Prama designer an abutment, a zirconia abutment that goes very precisely on the neck. And when we get on the neck of the implant, you should think of a monolithic zirconia crown. I'm not getting on the neck with a thin layer of zirconia, but most of the time, as you can see in the picture here, the crown is thick. We have a monolithic zirconia crown, which is very resistant. So we don't have issues of chipping at that level. And then we can combine actually zirconia to titanium at that level. Again, the implant abutment connection is one thing. The emergence profile that goes on the neck is another thing. So I can say that it works very well. But again, in order to achieve a crown that goes on the neck, we have to plan this in the first place with a proper exact position of the implant. Did I answer to you? I don't know if there was the answer. I mean, the question you asked. I don't know. Let me know. I mean, okay.
Now, actually, I saw there's one paper published inside, the primer, implant compared to the Nobel, the other type of implant. So in the paper, they said, because the color part, convergent color part, and so transgingival design. So, but the color part, they use a different material. So the whole body, like implant body, tapered body, they use a titanium. But for the color part, they seem to added, zirconium there. So basically, the coating part for the collar, the neck part, it seemed like different material. It's not just
now I understand you. Now I
yeah,
understand
it's a
you.
kind
Sorry
of a
about
zirconium.
that.
Yeah, it's a zirconium titanium. So this
Is
is
it still titanium? It's still titanium, but just the surface is different. It's titanium. The body of the implant is ZRT, and the neck is UTM, but it's the same titanium.
same titanium, but
Correct.
but do they added zirconium there? I think they seemed like they said they added zirconium, especially on the collar part. So this is part maybe helps the gum tissue or gingival tissue attach to the neck part
Well, to be honest, I don't know about that. I know for sure that the neck of the implant has got a micro, ultra thin, I would say, ultra thin microsurface.
Okay.
Only that. Then, if you look at the neck, if you keep your
Mhm.
implant in your hand, if you look at the neck, it looks like a polished neck. You don't see it.
Okay.
You only with the micro photography you can see and you can appreciate the 60 microns
Mhm.
draft. Okay, so just the surface, ultra thin micro surface, and that's why it's ideal for soft tissue.
Okay.
The fibroblast, when they get on the surface of the neck, they find immediately like the ideal space to get adjusted into it.
Mm-hmm.
Then what happens, what they told me actually from my histologic paperworks, but clinically speaking, my feeling when I see the peri-implant tissue around the neck is quite positive, because I can see and I can tell that the soft tissue is surrounding the neck like a real natural barrier. And that's what I like about it.
Okay. And I last question. So
Yeah.
I remember the last case you showed in the
Yeah.
PPT. When you finish the implant, I see the medial part, between the neighbor teeth, and there is a piece of, part of, radiolucency in the X-ray. So, so that part, do you have any concern? And, did you do anything for that part?
Let me show. I want to see it with you. Let's go to the case.
Yeah, the last case.
Talking about here.
Okay.
Yeah,
Dr. Conti, you share your screen. Yeah.
Okay, I need to share again, right? Am I sharing? I don't see. How can I share it? Here. Sorry, guys. Oh, here we are. So, are you talking about this area?
Mm-hmm.
Oh, let me see.
The X-ray, the pictures.
The X-ray here.
Not this one.
Oh, maybe here.
Yes.
Okay. Let's see together. I want to understand. Let me see together. Okay, here. See, when you look at the X-ray with Prama implants, is a little bit different from a bone level implant.
Mm-hmm.
As you can see, the first X-ray is the day 0 when I place the implant. These are biomaterials, all right? Then after a few months, I still have a little bit of biomaterials right here. You can see, right?
Mm-hmm.
Here and here. And then after 1 year, after 1 year, if you look carefully, the bone remodeling is completely different from a bone level implant, because the bone remodeling here and here is following the emergence profile of the crown. It's like an ovate pontic. Plus, if you can see, here we have the cylindrical part, and then cylindrical part is into the bone, is also integrated.
Mm-hmm.
That means that nature is working. It's got its own rules. Anytime I have an emergence profile of the crown, nature is going to create and find the space itself for the soft tissue. So in this case, the emergence profile of my crown is giving the rules to the bone, and the bone is remodeling according to the emergence profile in order to give the space for the soft tissue. I don't know if I answer to you, but
So yeah, so my question is on the apical part, between the implant and the neighbor root, the radiolucency. It's not the emergency valves. It's not the cylinder part. It's on the medial side, the apical part of the implant.
yeah.
Yeah.
Well,
yeah.
I think it's a defect of the X-ray. Look.
Yes. Is it getting better?
Yes, I can see it here. Oh, sorry about it, but I don't know. It's probably the defect of the X-ray, to be honest.
Okay.
I don't see. No, here is perfectly integrated.
Okay.
Yeah. Yes. Sorry about that. I thought you talking about the bone remodeling around the neck of the implant. No, here is perfect, I think. Yeah. See, it's different from here to here to here. At different levels, and through different timing, we have different exposure. I mean, different picture. I think it's just the fact of the picture, probably.
But the coronal part, like a cylinder part, the bone, remodeling is amazing. It seems like
it's different. Just
really good.
Yes, I think the bone remodeling is following the emergence profile of the crown, as you can see, and then the transition zone is, ideally speaking, into the bone. This is where it's supposed to be.
Yeah, like this is amazing, wonderful. Yeah, very good case. Thank you.
Thank you. Thank you.
Thank you for your time.
Thank you. I think, Dr. Candy, your area already 5 o'clock or 4 o'clock morning. Okay.
No, it's 4 o'clock or something.
Yeah, I think you have to take care of yourself. Okay, have a rest.
Yes, very nice. Okay. Thank you very much.
Yeah, we hope in future and Dr. Candy can come to US. Okay, we can.
Absolutely. I can't wait to.
Okay.
I'm looking forward to meeting you guys.
Whenever
it was very
time.
nice to me. Thank you very much.
Yeah, thank you. Yeah.
Thank you.
Thank you, Amy.
I think today we stop here. Thank you very much.
I really appreciate it.
Yeah.
Hope to see you soon, though.
Thank you, everybody.
Have a nice evening.
Yeah.
Thank
Bye.
you.
Have a nice week.
Thank you.
Thank you very much.
Bye-bye. Have a good day, Dr. Candy.
Good evening. I need to leave the meeting. Yes, here. Bye-bye.
Okay, yeah.
Thank you.
Bye-bye. Yeah.